Thank you. Good morning, everybody. Dr. Politi, Leo. Leo, I have understood after the excellent level of this morning that the real reason you invited me, I have a very precise job to downregulate the level a little bit. And I know
good start.
I am a friend of yours. I will make it.
I was thinking about you when I attended the previous lecture, yes.
So, thank you. Well, management of heart failure is the very essence of cardiology. I would need a couple of months to address a little bit this topic, so I will need to summarize as much as I can the whole topic. I will just provide you with a couple of suggestions of what is changing in this very moment in the cardiological field in terms of management of heart failure, and what can be the picture in the next 10 years' time. And in doing so, I will introduce a little bit of the framework or the definition of congestive heart failure. I will challenge a little bit the title I've been given, and I will try to convince you that congestive chronic heart failure is not only chronic, is also an acute disease. I will introduce with the new evidences. I will not annoy you with the digitalis. I will try to summarize as I can the issue, and also to introduce a little bit the topic of non-pharmacologic, non-device, non-surgery approaches in the management of the disease, and introduce to you a couple of uncertainties among the thousands that are available. So one can say, what do we need definitions for? Well, this picture was very common when I was a student, and it was from an atlas, the Ciba-Geigy-Netter atlas. Even today is used quite oftenly, and in the left side of the picture, it was congestive heart failure condition, in the middle, acute heart failure condition. But I challenge you, please come in any cardiological department and try to find a pure congestive heart failure picture. It's much easier to find it in the pulmonology department. It's extremely rare in the cardiological department. And I challenge you to find anywhere the kind of phenotype of what it was intended for acute heart failure. I think that today, a condition of pure dyspnea with no signs of low cardiac output, it does not exist anymore. So we need a little bit of definitions. This is a common phenotype of heart failure today. The disability burden is not massive. It's usually general practitioners take care of these patients. This is a kind of patient that the internists are quite used, where heart failure is in the context of a complex comorbidity condition. This is the kind of patients cardiology are dealing with more and more often. So the concept also that has been introduced by Leo of the need to take care of these very intensive and demanding kind of patients is important. So this is just to say the heart failure is not the disease we have been studying on the books when we were students. And I'm talking also to the younger people present here. The phenotype of heart failure has changed in the last 15 years. How is changed? This is just to put the heart failure in the context of the complex diseases. This is a survival curve in 2 decades, the 90s and the end of the century in Sweden, but all over the world you can have the very same picture. Why I'm showing that? Indeed, lung cancer has a very bad prognosis. In the 90s, heart failure was this survival curve that was much worse than, for instance, colorectal cancer. In 10 years, the survival expectation for heart failure has quite increased, is now very close to colorectal cancer. This is not because the treatment of colorectal cancers has been improving the prognosis of patients, but simply because the cardiologists have been lucky enough to have effective drugs to treat this kind of patient. And to show this in a different way, this is how the heart failure natural history is today. We have not been able, cardiologists have not been able to modify the prognosis of the patients just to make this a really chronic disease in the sense that this lifespan of this patient is extended over a longer period. Put also on the same issue that the treatment of acute diseases, like for instance coronary artery diseases, we have transformed acute diseases into congestive heart failure. Congestive heart failure is there, we can prolong survival, but this simply heightens the need for treatment of this kind of patients. So how is nowadays the natural history of chronic heart failure? This is a classical scheme. Maybe you can think this is a little bit like the natural history of COPD, because there is a quite long asymptomatic phase. Then something happened, and the clinical status of these patients became worse. This is diagnosed, eventually admitted. Then you can have a recovery. Again, nothing changes in the sense that the disease progresses, and then you have again an acute phase. This is named acute heart failure in the context of chronic heart failure. And this can be repeated over time, eventually 2, 3, even more times, and probably this acute episode is able to influence the subsequent prognosis of the patient in the sense that the cardiac function is influenced. Again, it's very similar to COPD. What does it mean from the practical point of view? That whatever the definition you adopt of chronic heart failure, there is we have to take into, it doesn't work. You have to take into account the possibility, and that occurs quite often, of a gradual and rapid change in heart failure signs and symptoms, resulting in the need of urgent therapy. Is only an issue of therapy? No. These survival curves taken from registries. Very same patients enrolled during the stable phase of the disease, or enrolled into the registry during the acute phase of the disease. And I think there is no need for any explanation of these patterns, also in respect of acute coronary syndromes that in this period are absorbing the majority of resources in cardiology. This is the same story in a different way from a different registry, just to become familiar with numbers. You can see the life. The time here, we are talking about 3 months, mortality of 1 year, sorry, mortality about 5–7% if the enrollment has been during the chronic phase, almost 30%, 25 to 30% if the enrollment occurred during the acute phase. That is to say, when acute heart failure insists over a chronic phase, is a problem for the patient. I will make it. The impact of acute heart failure or acute phases over the natural history of chronic disease is so huge that the cardiological community is trying to establish common behaviors and patterns and position papers and consensus in order to identify, this is an example, hospitalized heart failure as a new entity and developing new therapies to improve outcomes. Let's move on a little bit about treatments and new evidences. This is the history of treatment of heart failure. No, I'm pretty sure you are confident with all these kind of treatments. These are RAS inhibitors, ACE inhibitors. These became popular at the late 80s. At this phase, there was the recognition of neurohumoral activation as an important pathophysiologic determinant in the natural history of the disease. This is the use of beta blockers after the appearance of the first trial employing beta blockers while they were contraindicated actually. Before, this is the use of RAS inhibitors. This is the use of anti-aldosterone agents. These compounds are the common and the most used drugs in the treatment of the disease. And to show you the impact of these treatments on the patients, this is, for instance, we can assume any possible value with the traditional diuretic treatment. After the introduction of ACE inhibitors in the trials, this was the effect size, the reduction of the relative risk. And I can tell you, whatever is the absolute risk of the population you start studying, the relative risk is more or less the same in every strata. This after the introduction of beta blockers, a further 30% reduction of the relative risk. This is after the introduction of aldosterone antagonist, a further reduction of 20% of the relative risk. This has changed the expectation of life of the patient, but not the, indeed, not the reversal of the disease. And nowadays, it is class 1, strength A, the use of an ACE inhibitor, and only if ACE inhibitors is not tolerated, the use of A or B. And every time I have the privilege to speak in front of internists and pulmonologists, I like to stress the concept that from the cardiological point of view, to employ an ARB or an ACE inhibitor is not the same thing. Add a beta blocker on top of ACE inhibitor, then if symptoms are still there, add a anti-aldosterone. This is class 1 strength A, so no doubt about. What do we have as new drugs over the last years? Well, this has been disappointing in cardiology. After the introduction of antineurohumoral, a lot of groups thought to introduce substituting hormonal, natural occurring hormones, like for instance, adrenaline-natriuretic peptides. 3 trials, failure. All anti-inflammatory or antioxidant trials, for instance, with statins or with biological compounds against cytokines, failure. And this is the picture for acute heart failure. Not a single trial in acute heart failure produced any evidence of an effect. And I can tell you, after I had this slide, there are some other compounds in the second row. And who is familiar with the cost of developing a drug, here you can realize that there are more or less $5 to $10 billion buried in the ground. It's quite an investment, but also think not only the economic burden, but also the fact that today, we do not have a single treatment for the acute phases of reacutization of heart failure capable of modifying the natural history of the patients. This is even more important as a price. There is a single compound that has appeared, that has been proven to be effective in the last 15 years. That is, this compound, is ivabradine, is the first a new molecule in a new, with a new pathophysiologic mechanism, acting only on the sinus node, on the IF current that is responsible for the polarization. This means that no effect on inotropy, no effect on the vessels, just decrease of heart rate. And this has enabled cardiologists to better understand the importance of heart rate as a pathophysiological determinant in heart failure. These are the results of the study, more or less consistent reduction of 20% using this treatment on top of ACE inhibitor, beta blocker, aldosterone antagonist. So on top of 3 very effective treatments. And what I can try to say that is, even if the mortality of heart failure is so high, to find a molecule effective on top of 3 or 4 very efficient treatment is an hard task, a huge amount of money, and a terrible effort to be proven. Ivabradine is today a 2A class B indication. in our guidelines. Let's move a little bit on non-surgical devices. I know those of you not working in a cardiological department, you are annoyed of all these pacemakers we are using. This kind of treatments, however, has further decreased of a gain of 1/3 the relative risk of events in heart failure patients. And this is not trivial. We have two more important kind of devices. One is cardiac resynchronization therapy, that is the employment or the selective activation of the more delayed part of the heart. In this case, there is a lead in the lateral wall. The images should start working, but this is not the case. In the case, you could see the efficient effect of this treatment. I hope that in this case you can realize, oh yes, this kind of treatment is not only able to correct the regional wall motion and the paradoxical wall motion that occurs when there is a delayed conduction within the ventricle, more important in the left bundle branch block. It's also able to introduce further improvements of the heart function, and this is a real patient. I've seen it. Yeah, I think it's very not easy to understand how, with the long term, the heart size has decreased, and the major effect on the degree of mitral regurgitation. Indeed, this is a very paradigmatic case. I have never seen anything better. It's very rare, and actually 1/3 of the treated patients do not respond of this therapy. And one of the major challenges would be, and we do not have the capacity to understand who will not. I will not annoy you anymore with survival curves in this case, but there are several studies demonstrating this. But if we think, again, on the arrhythmic problem, when I was studying, the ventricular ectopy was a marker of bad prognosis. We used compounds to reduce the number of ventricular beats, and we increased the rate death of the patients. Today, there are no antiarrhythmic drugs that are recommended to prevent sudden death in heart failure. Ectopic activity is not a target for drugs. It's a target for automatic implantable cardioverter defibrillator. Where there is a very important issue that I would like to share with you. This is one of these trials demonstrated that respect placebo, respect amiodarone, the implant of the device was effective. Where is the trick and the important issue for physician is here. The effect is not in the patient with the more severe symptoms. We name it class 3 patient, dyspnea and effort limitation. Patients in amiodarone do worst. The effect is only in the less severe patients. This can be obvious. Usually, the most severe patients do die for pump failure. The less severe patients do die for sudden death. But there is a consequence on this. The possible, the number of patients that can be implanted is, in this case, huge. So even if the cost of one of these devices has decreased, the total number of devices that has to be implanted is huge. In every part of the world, we are treating only a minor part of the eligible patients. This is not only in Italy. These are the recommendations for this kind of devices. Again, class 1 strength A. And the next step is that this kind of devices will be able to do much more. It is very common even today, the presence of impedance sensors in this kind of, that can measure the tissue congestion. And there are prototypes in a very advanced stage of development, even able to measure hemodynamic parameters. Surgery and surgical devices. Very brief. I think that we all are used now with the possibility to implant percutaneously aortic prosthesis, and this is an example. Now we are moving to the mitral valve. And this is not a secondary issue. Think to the fragile patients aged 80 with complex multimorbidity that were not eligible for surgery, that now become eligible for treatment. Only the prosthesis is 30,000 euros. Only the prosthesis. It's more expensive to implant one of these prostheses than to do the operation. Further step, and it is present in the guidelines, are ventricular assist device. This is one of the first generation devices, drawing blood from the apex and ejecting in the aorta. This is clearly advertisement, but today, after almost 10 years of the first clinical trial, this is the issue. Medical therapy, continuous flow devices that can be as big as this one. And here the cost is impressive. I'm almost at the end. Non-pharmacologic, non-device, non-surgery approaches. Very briefly. A short example. When I was studying, sodium restriction was the first recommendation. There is any robust evidence that sodium restricts benefits the patient. Actually, it is through the opposite. This is a controlled randomized trial. Normal sodium compared to low sodium. Normal sodium is 120 millimoles of sodium. That is more or less the sodium that is present in a pizza. Then this is the sodium of a normal diet, sodium diet, to 80%, to 80 millimoles per liter. And these are the results. Normal sodium, low sodium, these are the events. The sample size was not big, but this study is mentioned in the guidelines. And also telling that there is no reason to oblige patients to suffer a miserable life to eventually go performing worse in terms of survival. Just to mention, there are still uncertainties. Remote monitoring. This can be done today even through pacemakers that can communicate with the or serial monitoring of natriuretic peptides. We don't know if it is useful for the management of patients. And this is a message I would like to tell you. The use of biomarkers will impact on our practice in the next few years. This is the document from an agency, intergovernative agency, that is promulgating recommendation and policy issues on development and uses of biomarkers in health. And I can tell you, apart from the interest physicians have in this issue, but the regulators are extremely interested in this field. The Italian Medicine Agency, inspired by a common policy that is European, so not only in Italy, but also in the country of the foreigners' guests, has established 2 programs in heart failure. No drug, nothing, but the 2 programs are how to overcome the concept of randomized clinical trials we have nowadays, and what can be done in order to develop new biomarkers or to implement an effective use of biomarkers in the clinical practice. And this is the concept of precision medicine. If you are thinking to apply for the next calls from IFA, start thinking on this field. We will not have any chance to be founded if you are not in these 2 fields. And we are waiting for this that is behind the corner. I know I had to make very brief and superficial survey. I like to summarize what I've been trying to tell, but I know I did not succeed too much. Well, heart failure phenotype has changed. And this has major implication for the management of these patients. We will not treat patients in 5 years' time how we were treating patients 10 years ago. There is a major unmet need. Treatment of worsening heart failure. As I told you, there is any compound, any drug effective in this field. And it's really the subpopulation of patients who bear the worst prognosis and where the need for the medical development is urgent. No real important, apart one molecule, progress in pharmacological treatment. Maybe at least at the point of our pathophysiological knowledge, we are at the top of what we can obtain with medicines. And last, but I think more worrisome, technology seems to be all about the future. And this will take a major challenge that is not only economic, but more than economic. It will be cultural. We have to learn how to use this technology and to understand this technology. And we should not forget ethical issues, because we will be treating patients in the condition Leo mentioned today that do open ethical issues as well. Thank you very much for that attention.
Oh. Thank you very much, Professor Ceconi, for your excellent and exhausting presentation. I think that we have a lot of questions. First of all, Professor.
You certainly have kept the level very high. Thank you very much.
We are friends.
The question is, you probably did not want to talk about this in purpose, but and if so, I would like to know the purpose. But what is the role of heart transplantation? That obviously is an important issue, I think, in this matter.
I am emphasizing an issue. I think heart transplantation is not really Gaetano is here that he is an expert in heart transplantation, but I think heart transplantation is not a real resource in treating this patient. Why? Organ availability is becoming less and less real. It has been good to introduce the helmet in Italian circulation, but this has cut the resource. I'm joking, but this is serious. Then, the kind of patients we are treating are usually of advanced age, with complex comorbidity, with diabetes, with polyvascular disease, that most of the times are not eligible. Indeed, if there is an organ, a young person with myocarditis or primary dilated cardiomyopathy can be eligible. But a substantial part of the patient do die in the waiting list when they enter the waiting list, because now it seems that the waiting list, the mortality in the waiting list is lower simply because they do not enter many times in the waiting list. The use of ventricular assist device is proposed also as a bridge to transplantation. Not more, well, it was introduced as a bridge to transplantation. Now it's considered as a destination therapy. But its use of ventricular assist device as a bridge to the availability of the organ can be an issue. But if we consider the number of transplants in Italy, last year how many were them, Gaetano? How many transplants have been performed in Italy last year?
Below 10.
200. The town mentioned by Leo was 25,000 people. So indeed, it's an important therapy, but it's not really a resource. When I can treat 200 patients on a huge number of, but it can change the life of young people with a primary disease, no comorbidity, but just 200 of them.
Another question, Leo, please.
Claudio, trying to bridge your lecture with the previous lecture, and you showed the imaging of a decompensated heart and the same heart after compensation. So the question is, what is the pathology of the decompensation? Do you have fibrosis of the myocardium, and is this treatment that you showed to be very beneficial affecting fibrosis of the heart or not? And it's not only to you, but also to Gaetano and maybe
I will
Massimo.
be very brief, waiting for the answer of Gaetano. In remote, or even in ischemic cardiomyopathy, fibrosis is present in remote zones. So fibrosis is present. I can tell you the effect, the success of resynchronization therapy, for instance, is related to the extent of scar. This is obvious, but we are not. But in the single patient, does not predict the response. So there is a relation, but still is not useful, at least today, to understand, to select the patient. For the pathophysiologic insight, I wait, Gaetano.
No, certainly we have to distinguish among the causes of heart failure. Ischemic heart disease is fibrosis. That is loss of myocardium. You lost myocardium there, and you are unable to find a replacement of myocardium, stem cells maybe. No, but...
Yeah, but does this reverse? Is there any evidence that treatment reverses this fibrosis?
No.
Okay.
No, there is no evidence. The only way is to have a low resistance at the periphery.
Gaetano, I'm sorry, can I jump in on this very issue? The interesting thing, because it was relevant to the question, not only in the scarred zone, but in remote zone, interstitial fibrosis increases.
Yes.
And but there are examples in vivo of reverse remodeling of interstitium. But like the case of the liver, nothing is being produced in patient. Sorry.
Another aspect is diastolic congestive heart failure. That is congestive heart failure due to diastolic dysfunction in the late stage of hypertension, for instance, hypertensive heart disease. So in that condition, I am not so sure that fibrosis is the cause of failure. So could you come across a bit on diastolic dysfunction? Because it's emerging as a 30–40% of cases of congestive heart failure.
Thank you. I'm very happy. I will try to be very brief. One, now I agree completely with you. Now there is a consensus, at least at in the European Society of Cardiology, not to name it diastolic heart failure anymore, but to name it heart failure with preserve when it is above 40% ejection fraction and reduced ejection fraction, and to avoid the use of term diastolic. This is true even today. When we are students, we have been taught that the early phase of diastole is an active process, and therefore is something different than the stiffness of the ventricle affecting the late part of the diastole. So I completely agree with you. The issue is that even if in preserved ejection fraction patient, the prognosis is similar to the low ejection fraction patients. And again, we have no specific treatment in this patient except in cardiomyopathy, the use of a calcium antagonist, and in general to decrease heart rate. So our therapy is really failing.
Thank you. Grazie, Claudio. Thank you.